seizure training, and it's a training about seizures and emergency diastat use for non-medical personnel. We're going to recognize common types of seizures and possible impact on students, know appropriate first aid, and recognize when a seizure is a medical emergency. So what is a seizure? It is a brief excessive discharge of electrical activity in the brain that alters one or more of the following: movement, sensation, or behavior. Now, what is epilepsy? Epilepsy is a chronic neurological disorder characterized by a tendency to have recurrent seizures, and epilepsy is also known as a seizure disorder. So did you know that most seizures are not medical emergencies? Students may not be aware that they are having seizures and may not remember. Epilepsy is not contagious. Epilepsy is not a form of mental illness. A student cannot swallow his or her tongue during a seizure. And do not ever put anything into a person's mouth while they are having a seizure. So common causes of epilepsy. So for 70% of people with epilepsy, there is a no known cause. For the remaining 30%, there are common identifiable causes, which include brain trauma, which could be an injury at birth, which is the leading cause in teens and adults, brain lesions, which could be tumors, poisonings such as lead level toxicities, infections in the brain like meningitis or encephalitis, or abnormal brain development. So seizure types. There are generalized seizures, which involve the whole brain. The common types include absence and tonic-clonic. Symptoms may include convulsions, staring, muscle spasms, and falls. So an absent seizure is a pause in activity with a blank stare. There's a brief lapse of awareness. Possible chewing or blinking motion can be seen. They usually last between 1 and 10 seconds, and they may occur many times in a day. And they are easily confused with daydreaming, a lack of attention, or ADD. These used to be called the petit mal. The other symptoms may include eye fluttering, slight head movement, and some mouth movement. As an absent seizure ends, the student will pick up where he or she left off and resume normal activities, almost as if nothing happened. There is no first aid necessary for an absent seizure. Absent seizures may occur in clusters, which may lead to a brief period of disorientation. And recording seizure frequency using a seizure observation record can help with identifying possible triggers. So generalized tonic-clonic, there can be a sudden hoarse cry, a loss of consciousness, a fall, convulsions with stiffening of the arms and legs followed by rhythmic jerking, which is normally what we think of when we hear the word seizure. Shallow breathing and drooling may occur, and then possible loss of bowel and bladder can happen. Occasionally, their skin, nails, and lips may turn blue. That doesn't mean that they're having a lack of oxygen. It's just part of the reaction to the seizure. And then generally it lasts 1 to 3 minutes. They're usually followed by confusion, headache, tiredness, soreness, and speech difficulty, which is called the post-ictal period, meaning after the seizure. So generalized tonic-clonic continued. These were previously called grand mal seizures. And this is the seizure that most people think about when they hear the word epilepsy. Initially, the student will lose consciousness and fall to the ground. It's not quite the same as fainting. There is a distinct difference. It's hard to describe until you've seen it. But if you have a student that has a seizure, you'll know it's happening when it happens. So as the diaphragm contracts, the student may produce a loud cry. Sometimes it can be called a horror movie scream. It can happen because the diaphragm is contracting. The eyes may roll up or turn to the side. The body usually becomes very rigid before the convulsions begin. The student may bite his or her tongue during the seizure. and then several hours of rest may be needed after the seizure, which again is part of the post-ictal period. So a focal seizure. So these symptoms relate to involve any part of the brain affected. So the activity is localized to the part of the brain that they affect. A focal awareness seizure is full awareness is maintained. Rhythmic movements could be isolated to the twitching of the arms, face, or legs. So instead of the entire body going, it might just be one arm or one leg. They could experience sensory symptoms like tingling, weakness. They might hear something specific or smell something. They might taste something, a feeling of upset stomach or visual disorientations. Something to keep in mind is a lot of our students can't tell us if they're having any kind of sensory symptoms. But if you are with a student that has any kind of seizure disorder, usually you'll know the difference in their behaviors. So sometimes we get to know them and we know, hey, this is a trigger, this usually happens, and we can just prepare in case something goes down. Psychic symptoms like deja vu or a hallucination, a feeling of fear or anxiety, or something that they just can't put their finger on, they can't explain it. Something else that our kiddos might not be able to tell us, but that's okay. They usually last less than a minute, and these sometimes can be confused with acting out. So a complex partial seizure can last from 30 seconds to 2 minutes. These seizures may have an aura. Usually people will complain that I see a certain color or a certain visual, something goes on visually, and that they know that they're going to have a seizure. These include some automatisms like lip smacking or picking at the clothes, fumbling, taking off clothes sometimes. They may become unaware of their surroundings and they might even wander off. Many treatment options are available that include medicines, diets, changes, surgeries, and devices. A person affected may be tired and have periods of confusion. So signs and symptoms of pre-seizure activity. So seizure symptoms in a specific person are generally the same each time a seizure occurs. Again, that will be that you'll get to know your student and know like that's how. Some students will have a definite sign that a seizure is about to happen called an aura, but our kiddos probably won't be able to tell us that. An aura may include, but it's not limited to, an odd taste or smell, a feeling of fear, a visual or auditory experience, or a tingling sensation. In some cases, an aura may allow the student to prepare for the oncoming seizure and warn others that a seizure is about to occur. Seizure triggers. So flashing lights and hyperventilation can trigger seizures in some students with epilepsy. Factors that might increase the likelihood of a seizure in students with epilepsy include missed or late medication, which typically is the #1 reason why somebody has a seizure if they are established with epilepsy. It happens more often than you'd think. Stress or anxiety, lack of sleep and fatigue, and hormonal changes. We see a lot of those kind of at the high school level. If our kiddos come in with epilepsy in our younger ages, they'll be fine. And then all of a sudden, once they get up to high school age, they'll change because of puberty. And that usually just means they need a medication adjustment, which will get taken care of with the parents and the doctor. So when is a seizure an emergency? The first time anybody ever has a seizure with no known history of seizures or no kind of medical diagnosis, it's always considered an emergency. A convulsive seizure that lasts more than 5 minutes is an emergency. Follow the seizure emergency definition and protocol as defined by the healthcare provider in the seizure action plan. What that means is every one of our students that has a seizure diagnosis carries around a care plan that says what to do if they have a seizure. Repeated seizures without regaining consciousness is an emergency. More seizures than usual or a change in the type of seizure. If a person is injured during the seizure, has diabetes, or is pregnant, it's always an emergency. If a seizure ever occurs in water, it's an emergency. And if normal breathing does not resume, it's an emergency. So dangerous interventions. We do not ever put anything in anybody's mouth if they're having a seizure. We don't ever hold them down or restrain them. And we do not attempt to give oral medications, foods, or drinks during a seizure. Going back to the not holding them down or restraining them, we do put them on their side if they are on the floor and they are in a full-on convulsive seizure. That is not the same thing as holding them down or restraining them. We do this to keep an eye on their airway and to also protect their head. First aid intervention. So the first thing you're always going to do is stay calm and track the time. Tracking the time is important because a seizure lasting longer than 5 minutes will require an emergency intervention. We also track the time because all of our students have seizure plans. If they carry an emergency medication, there's a time that the doctor wants the emergency medication administered. Usually it's the 3-minute mark. So we always check the time on either a timer that the student has in the bag, on your watch, on a phone, something. We're always going to protect them from possible hazards, chairs, tables, sharp objects, etc. We would be moving things out of the way, like if they fell to the floor and there was chairs nearby, we'd move the chairs, we would get everything away. We turn the student on their side. Turning them to one side keeps the tongue from blocking the airway and allows saliva and or blood to drain from the mouth. We're going to cushion the head with the palm of your hand or another soft object that can be used. We usually have head pads in all of our rooms, so we usually tend to go to those. After the seizure, we remain with the student until awareness of surroundings is fully regained. We never ever leave them alone. We're going to provide emotional support, and then you're going to document the seizure activity in the seizure log, which the student should have in their IRS binders. So emergency intervention, so Diastat. What is Diastat? So it is a gel. It's a form of diazepam. It belongs to the class of benzodiazepines, and it's known as an anticonvulsant. It is used for emergency seizure situations, and it's an anti-seizure medication. So how it works. So diazepam belongs to a class of meds called benzodiazepines, and it produces a calming effect on the brain and the nerves. So the Diastat is a Schedule 4 controlled substance, and it is thought to work by increasing the effect of a natural chemical, which is the GABA in your brain. So it's an amino acid, the gamma aminobutyric acid, and it's a neurotransmitter in the brain, and it dampens down the excitability of the neurons, which in turn lessens those electrical impulses that may contribute to seizure activity. So it's a fancy way of saying that the brain is short-circuiting in a way because there's too much electrical activity going on, and administering the emergency medication stops that and calms everything down and kind of brings it back to center. So types of seizures that require Diastat. So there are 2 types of seizure emergencies: status epileptic. I always butcher this, you guys, and I'm really sorry. So it's status epilepticus, and it's a prolonged tonic-clonic seizure that lasts for an extended period of time. So this period of time is determined by the student's physician, and for some it's 5 minutes, but for others it could be less, and for somebody else it could be a little bit more. I have seen one that says not to administer the emergency medication until 10 minutes have passed. But again, it's student specific. So if you have a student with seizures, get to know their plan. Don't be afraid to read it, ask questions, and just get comfortable with it. An acute repetitive seizure, so like a series of seizures or a cluster. Each lasts a short period of time, and in between the seizures, the student regained consciousness. We see these sometimes with absent seizures as well, not just the convulsive seizures. So indicators for Diastat administration. So this medication is used to treat episodes of increased seizures, like an acute repetitive seizure, the cluster, the breakthrough, in people who are already taking medications to control their seizures. So you're not going to have a kid that just carries around an emergency med without already having other meds at home that they take. It's only recommended for short-term treatment of seizure attacks. It's not for ongoing daily to use for preventing seizures. They're not going to come to school and, call down to the nurse or the CRMA to get this medication on a daily basis. This is only used in an emergency situation. So uncontrolled seizures that can turn into serious and possibly fatal seizures that don't stop, which is the status epilepticus. So side effects of Diastat, there can be drowsiness or sleepiness, dizziness, diarrhea, and an unsteadiness, which makes them a fall risk because it makes you drowsy. A standard procedure for administering Diastat. So you time the seizure and you are going to get ready to administer the Diastat. So a kiddo that carries Diastat, it is a rectal gel and it comes in a case that looks like this. And everything that you need will be in this case. So if the order states that Diastat is to be given, you're going to proceed to the following steps below. This says you're going to have somebody call 911. And you call 911 when the medication is administered. And then this is actually backwards, but that's okay. So you're going to place the student on their side where they can't fall, and you're going to get the medication or have someone get it from the area that it's kept. It's always in their med bags though, with a blanket or something. So you're going to get out the syringe. Okay, so we're going to open this up. And this is what you're going to get out of the box. You're going to push your thumb up and remove the cap from the syringe to be sure the seal pin is removed with the cap. And then you're going to lubricate the rectal tip with lubricating jelly. Turn the student to the side facing you. What I would prefer you do is, they're in a seizure, you're not really going to be able to turn them. So whichever side they're already on, it's totally fine. You can use that one. And you're going to bend the upper leg forward to expose their bottom. And then you're going to separate the buttocks and expose the bottom. And then you're gently going to insert the syringe tip into the rectum. And the rim of the syringe should be snug against the rectal opening. That just means you're going to go all the way in. And then you're slowly going to count to 3 while gently pushing the plunger in until it stops. And then you're slowly going to count to 3 before removing the syringe from the rectum. And slowly count to 3 while holding the buttocks together to prevent the medication from leaking back out. And then you are going to keep the student on the side facing you, or whichever side they're already on. They're going to note the time given and continue to observe. And then we're always going to keep the tube to be able to hand it off to EMS and say, this is what we gave, this is the amount we gave, and this was the time that we gave it. Follow-up observations after Diastat administration. That just means that while we're waiting for the ambulance to arrive, we're keeping an eye on their breathing, because once this is given, this could cause them to stop breathing. Usually rare, but it can happen, and we always just want to monitor to make sure that that doesn't happen. So here is the medication, and it comes in the applicator. And everything you need is in there. The lubrication's in there. There's usually a pair of gloves in there. And if there should not happen to be a pair of gloves in there, don't panic. There's gloves in all of our rooms. So the Diastat emergency medication is packaged in applicator form, and the applicator dosage has been dialed up by the pharmacist before leaving the pharmacy. Look for the green ready band around the tip, which is this part right here. Well, I can't see it. There we go, right here, this part. If you see a red band around the tip, you're not going to use it because that means it's not ready. And the proper dosage is got a little window that you can see that what it says. This is the window to tell you the dose, and it should always match the plan. And here we go. We're going to confirm the dose and the green ready band are visible. And this here would be your window, and then the green ready band. So administering it, you're going to have them on their side. And then you're going to separate their buttocks to expose the rectum. And you're going to gently insert the syringe into the rectum, and note the rim should be snug against the rectal opening. So you're going to get them on their side. You're going to have this out, and you're going to take the cap off. And inside the cap is the plug that they were talking about back a couple of slides ago. That will come right out. And this is your This is what's actually going to go into their rectum. So this is the part you're going to lubricate with the lubricating jelly that's in the box. And then you're going to take this, and this is the part that's going to go snug against the rectum. So you're going to insert it, you're going to insert it slowly and count to 3. You're going to say in, 1, 2, 3, and you're going to go in. And then you're going to push the plunger. So you're going to say plunge 1, 2, 3, and then get it down all the way. And then you're actually going to hold their buttocks down and say hold 1, 2, 3. And then you're going to say remove 1, 2, 3 and move it out. And then you're going to set this down, and then you're going to hold the butt cheeks together and say hold 1, 2, 3 to prevent the leakage. So we don't want the medication to come back out. These are links that you can look up more if you want to learn more about seizures, diastat, or epilepsy at all. Sometimes we have students that will come in with what's called a vagus nerve stimulator. This is a stimulator that goes into the chest, kind of like a pacemaker, but it is an option that can reduce the frequency of seizures in people who haven't achieved control with medication. The vagus nerve stimulation involves the use of a device to stimulate the vagus nerve with electrical impulses. The device is surgically implanted under the skin on your chest, and a wire is threaded under your skin, connecting the device to the left vagus nerve. So it's always on the left side of the chest. When activated, the device sends electrical signals along the left vagus nerve to your brainstem, which then sends signals to certain areas in your brain. And this is what it looks like. This is where they insert it over here. It's our right, but it's actually the patient's left. And it just goes in and gets threaded under the skin and up through to hit that vagus nerve. So the simulator can be programmed to deliver electrical impulses to the vagus nerve at various durations, frequencies, and currents. Very similar to a pacemaker for your heart. The VNS is used as an alternate to assist with stopping seizure activity or lessening the length of time a seizure is occurring. Vagus nerve stimulation usually starts at a low level and is gradually increased depending on the symptoms and side effects. Side effects can be voice changes, hoarseness, throat pain, excitability, cough, headaches, shortness of breath, difficulty swallowing, and sleep disturbances. For most people, side effects are tolerable and they may lessen over time, but some side effects may remain bothersome for as long as there is use of the implantation of the vagus nerve stimulation. So the VNS magnet use. So the stimulator itself doesn't detect seizure activity. So when it's turned on, the stimulator turns on and off at time intervals selected by the doctor in the office, such as 30 seconds on and 5 minutes off. A handheld magnet is used to initiate stimulation at a different time. For example, an individual sensing an impending seizure, the magnet can be swiped by a caregiver for the person during an active seizure. So if we had a student that had a seizure and they had this, we would have a magnet that they would carry with them. And when we had a seizure activity, you would just literally wave the magnet over there and it would trigger the VNS stimulator to work to help decrease or stop the seizure. This is what the magnet looks like. Kind of looks like an Apple Watch. It's not that much bigger either. And it just literally, this is them swiping it over the space where the stimulator is. So magnet use directions, it can be used by the person with seizures or by another person. In our case, it would always be by one of us. Swipe the magnet across the generator under the skin, usually on the left side of the chest for 1 second. Start in the middle of the chest and swipe across the generator, counting 1,000. You're going to wait 1 to 2 minutes, depending on how long the magnet is programmed to deliver the stimulation. And if the seizure is still going on, you swipe the magnet across the generator again. You don't hold the magnet over the generator, as the magnet will turn the generator off as long as it's held over the device for at least 6 seconds. So removing the magnet will cause the device to go back to its programmed simulation cycles. So it's just, you start in the middle of the chest and you swipe out. And these are more links that you could look up to learn more. We don't normally have kiddos with a VNS, but it's one of those things that it does happen occasionally. If we ever get a student that had a vagus nerve stimulator, we would give you guys more training, make sure you're more comfortable. We would do individualized trainings with it. So you're never going to be alone. If you ever have questions, you can always come find somebody. We also have students that have a nasal version of Diastat. It's actually called Valtoco. It's not administered the same as the Diastat rectal gel. It comes in a little tiny applicator here. It will have an order for it, just like the rectal gel, but instead of going through and having to lay them down and insert it and counting, it's literally just like using saline nasal spray, or like if you have a seasonal allergy nasal spray you've ever used. The medication is packaged right here in this part of it. And once that student hit the convulsive seizure were to hit the 3-minute mark, usually, it's very simple. You just press it. Press it up. And that right there administers it. It's into the nose. So you're going to put this part up into the nose, push it down, one spray, and it's done, and it's administered. It does press a little hard sometimes, but the big thing is that even though they're having a seizure, sometimes they'll back their head away because it's kind of like an involuntary reflex. So once that's done, it's the same thing with the Diastat. You're going to call 911, and then we're going to be calling the parents, let them know what's going on. And then we always keep this as well to give to EMS when they come. That's it. Any questions, you can get help. We'll help you.